Hello, and welcome to the next edition in our Wednesday webinar series from Barnes-Jewish Hospital. I'm Jason Merrill. I'm here with Susan Kraenzle, who is the manager of the Joanne Knight Breast Health Center at the Siteman Cancer Center at Barnes-Jewish Hospital and Washington University School of Medicine. We love our names. And we're here today to talk about breast screening. It's a big topic of controversy. A lot of people don't know anymore as far as if you should get a mammogram at 40, do you do it every other year? So we're going to talk about that, but we're going to take your questions as well. So you can tweet us at BarnesJewish. Thank you for the graphic. Email us at barnesjewish@bjc.org, or visit us on Facebook at www.facebook.com/BarnesJewishHospital. I can read with the best of them. So I've got all that right here, and we do have a few questions that have already been sent in that we will be asking as we go along. So off the top, this August is a big milestone for breast cancer. Talk a bit about that.
So right off the top, we're especially excited here at the Joanne Knight Breast Center because this is our 25th anniversary of initiating our screening program. So mammograms have been around for a long time. But what we figured out 25 years ago, and sort of what the rest of the world figured out 25 years ago, is that if we do a mammogram on women of a certain age, just about every year, so if we do 2 pictures of each breast to kind of look at them for changes every year, we can maybe find breast cancer earlier. And we've been very, very fortunate here to have commitment by the Mallinckrodt Institute of Radiology, the School of Medicine, and Barnes-Jewish to really jump into screening for women and have two advocates and really pioneers in the field of breast screening, Dr. Barbara Monsees and Dr. Judy Destaway, who Dr. Destaway is at another program now, but of course we all know that Dr. Monsees is still here with us, but they really pushed for a screening program in the Midwest. And so at that time, they also recognized that we really needed to invite women to be screened. So, and we needed to make it as convenient for them as possible. So at the same time that we started our screening program, we also kicked off our first mobile mammography program, which is the oldest in the Midwest.
Okay, we'll get to all that later.
Okay.
But as far as mammograms go, 25 years of breast cancer screening, it seems like it's been around forever, but it is a relatively new breast screening tool. And there's a lot of controversy surrounding mammography, and we'll get into that as well. But what advice do you give women about breast cancer screening? What are the guidelines that you recommend?
We have, and you know, those guidelines have shifted a little over the last few years, so we absolutely understand why women might be confused. So absolutely, positively, hot off the press, last week, every woman over 40 should get a screening mammogram every year. Period. It's been proven. Secondly, she should understand what her breasts feel like. So, you know, we're not saying if you don't examine your breasts on the 3rd day of the month, every month you're going to get breast cancer and die. We're absolutely not saying that. We know that self-breast exam, there's no evidence that shows that we find breast cancer sooner. But there's a whole lot of women out there who say, I wouldn't have found my breast cancer if I didn't know what my breasts feel like. So we're saying, know what your breasts feel like. We're also saying, have your doctor examine your breasts regularly. Probably every year when you go in for your annual well-woman exam, you need to have a good, what we call a clinical breast exam. And more importantly, what we're finding through the years now is that we really, really need to understand a woman's risk for getting breast cancer. So we're learning more and more and more about risk factors and learning how to tailor screening practices specifically to women with certain risk factors. It's really exciting, and there's going to be much more coming out about risk factoring in the future.
Yeah. So what are the risk factors that would necessitate someone getting screened younger than 40?
She would have probably a very, very strong family history of breast cancer or other female cancers in her family. That's a big one. She would have had a risk assessment performed, which is something that we're developing here at the Siteman Cancer Center. and she will have spoken with her doctor to say, I've got this going on. Maybe we need to look at some earlier screening practices, some different screening modalities.
And all of this seems to make sense. The more you screen, the better your odds. But there's a real difference of opinion between physicians about this. Why is there this difference of opinion? Because a few years ago it was very controversial. There was a paper that came out that said women should, at 50, get biannual screening. And the American Cancer Society said, we disagree with that, as did the folks you work with in the Breast Health Center. Why is there this difference of opinion?
Well, I think that in the data that you're referring to came from the United States Preventive Disease Task Force, which looked at and the data that they looked at was important, and I don't think anyone wants to minimize that. But what they did is take certain data and look at it based on the number of breast cancers or deaths from breast cancer and the quality of life that screening and not finding breast cancer might have affected. So what the preventive task force said was that there doesn't seem to be enough evidence to scare women into having a mammogram every year. That it can lead to false negatives. The quality of their quality of life might be influenced by additional fear that's not necessary because the mammogram is going to be negative anyway. A little bit of radiation risk. And really, most women that we've talked to have said it's worth the little bit of risk that we have to deal with.
Yeah, that was actually a question we did have emailed from Judy, who emailed, is there a radiation risk from mammography?
No more of a risk than riding in an airplane, being out on a sunny day. And when I talk to patients, I sort of ask them to balance that little bit of risk, radiation risk, to, you don't get a mammogram for 3 years and you've got a breast cancer growing. Yeah. Most of them are more than willing to have the mammogram.
Yeah. And it's not hard for us to think of anyone in our lives that we know who's been touched by it, who's somebody in their 40s who's been diagnosed with breast cancer, and the screening, not screening at that age, that's where kind of the controversy comes up. Right?
Sure. Well, and even more and more, it seems like we're seeing women under 40 who screening has been shown just to not work for because their breasts are what we call dense, which means there's lots and lots of breast tissue in there, which creates a very, very cloudy sky. It doesn't give the radiologist that blue sky that older breasts have to look at it. You can see anything that jumps out. So, that's where a lot of the controversy comes. And that, again, is why we're really, really trying to learn about risk factors. What do we do to tailor a young woman's screening based on her risk? Does she need an MR? There's some thought that screening ultrasound might be a useful tool. And again, this is really the emerging science that we've learned so much about how to find breast cancer early that we're learning more and more and more. And within the next 10 years, we'll have tailored screening for everyone. It's really exciting.
Now, has this controversy affected the number of women who get mammograms? It's not something a lot of people look forward to having done. So if there's a way to get out of it for a subset of women, this is a nice way out to say, hey, I heard from doctors, they said you don't need it. Anecdotally, have you seen that?
Well, I think that, and speaking with my colleagues across the country, we're all worried that mammography screening rates are declining. We've certainly seen it in our practice. There's some other local practices that their numbers aren't exactly what they were a few years back. And again, this is anecdotally. I'm not quoting any data here, but we think that there's a couple of things happening. First of all, the economy's tight. People are not spending their dollars on health care. more and more people are losing their insurance. More and more people are having higher deductibles and copays where they just don't have the money to pay for mammograms. And I absolutely agree with you, Jason. If you've got a lot of other factors that are piling up to say, I can't afford it, I'm scared, and when some data gets thrown at you from many, many sources to say, well, you don't need one anyway, it's easy to say, see, I'm not going to do it.
Yeah. One of the things about the program here at Siteman Cancer Center that we offer is that we can help those who don't have insurance. It's a grant funded by the Komen Foundation.
Absolutely, absolutely. We at the Siteman Cancer Center have the largest breast health outreach program to take care of underserved, uninsured women in the state of Missouri. Probably one of the largest in the United States. Last year, we took care of close to 6,000 women who don't have insurance. And so we really try to drive that message home that, we will take care of you. You need to come in and have your mammogram. We'll get you in, we'll get you taken care of, and we'll find a way to get it paid for.
And I think there's a bit of a stereotype in the past about the type of person who might need that kind of assistance, but that's no longer the case.
No,
there are a lot of people that don't have insurance
Right.
anymore from their job.
Right. This economy has just blown all those what we knew were stereotypes. It has just blown all of those out of the water. Every day, our patient navigation staff, our team that cares for women who don't have insurance and can't afford to take care of themselves, every day we get, I had a job 6 months ago and now I don't. And then my husband lost his job. And, it's the stories are really, really tough to hear. But, again, we're very fortunate in St. Louis. We've got a very active program. There's several other active programs that big race has taken care of. And so we really feel very strongly that every woman in St. Louis who needs to have good breast care can have it done.
Okay. So how does that work if you we'll walk through how to even get a mammogram.
Okay.
But how does that work as far as it's for women of low or no income and no insurance?
There's some guidelines that we work off of, but really and truly, even women who have insurance can approach us if they have a deductible that they can't afford to pay for. We really need to have those women come to us that say, I just can't afford to have a mammogram, I don't have enough money, and we find a way to make it work.
All right. Well, let's talk about breast screening. Women hear about mammograms, breast ultrasound, breast MR. What is the standard? If somebody, they're 40, it's time for their annual screening. Mammography is the standard, right?
Absolutely. Screening mammography, those two views that take two pictures of each breast that we talked about earlier, is absolutely the standard. That is the proven modality to find breast cancer in its earliest stages. And the way that we do that is by looking at the breast tissue every year. And that's how we can see very subtle changes in the images.
Yeah. So what is the process for a woman who gets a mammogram if a woman has not had one before?
If she's not had a mammogram, she probably needs to have a conversation with her physician to say, I'm 40, and this absolutely should come up in her daily health care. I'm 40, you do this clinical breast exam every so often, I guess it's time for me to have a mammogram. I know I've heard it's painful, but, I really have to get it done. And then her health care provider will, I'm sure, say, it's not all that bad. At the Siteman Cancer Center, we do 120 of them every day. So we know pretty well how to get it done with minimal amount of trauma.
Now, there are other options out there that you hear about as far as breast ultrasound. Mm-hmm. Why would a woman need something different than a regular mammogram?
Again, Jason, that depends on her risk. So there's options out there to have screening ultrasounds, which really haven't been proven in the broad community to make a difference in finding breast cancer earlier. There's some good data out there, but we haven't had this 25 years to work with to say we think it's better. There are certainly instances where a woman may need to have a screening MR, but that again is something that risk has to be very, very carefully calculated. And MR is not a lot of fun either, and it's something that we're very careful here. Our radiologists review pretty much every request for a screening MR and make sure that it's a woman who needs to have one done.
And you have a new toy that very well may be the future of screening.
New toy.
Yeah, new toy. Breast tomography that allows the 3D view, but it's not really a 3D view. Talk a bit about that.
So it's actually called breast tomosynthesis, and what it does is creates a 3D mammogram. So the pictures that we take now, sort of we get a picture this way and we get a picture that way. And what breast tomo does is take those images, except doing the two, we do a series of slices. So it's sort of like going through a loaf of bread. You know, instead of getting the two slices out of the middle, we start at one end and go through the other. And it's really, really promising. We've got some images that we've done already as part of a trial that we've performed here at Siteman. That those images, if there's a mass there, it just sort of like jumps out at you, just like a 3D movie. It's very, very exciting. Again, we don't have that huge database that all the experience that we have with as with mammography to say this is how we need to take care of people, and this is how we need to screen women. But it's really, really promising. We're very excited about it.
And the benefit from one of the studies that's been done is that it reduces the number of callbacks for a woman to come back.
And that's one of the things that we're absolutely looking at. So, you know, if we take the two views and the radiologist sees something that might be a little shift in something, you know, in a little shift in the tissue, at this point, we would have that woman come back and say, let's get a couple of different pictures. Let's take a picture of it here. Let's magnify it. Let's press something out. And we really and there again is where the anxiety comes. Oh my God, I had this mammogram. I did everything I was supposed to, and now they call me back. I'm sure I have breast cancer. That's never the truth. If we have a mammogram that we need to take more pictures, it doesn't mean that you have breast cancer. It means that we need to take more pictures. And so tomosynthesis then may allow us to have those more pictures as we're doing the images. So something that we didn't see in these two images we might have seen as that breast tomosynthesis reconstructs the images in 3D. We're really, really excited about it.
And it's all done digitally, and that might seem like old hat now, but when people think of X-rays and images, they think of the big image getting popped into the light machine.
Right.
That's all digital now.
Right.
Everything is, and there's an image of Barbara Monsees, who is the chief of breast imaging here, looking at breasts on a screen. Rather than the film. So what are the advantages of looking at it digitally versus the old film?
So there's lots of advantages to digital. And again, a few years back, probably 10 years back, there was a big, huge international screening trial that asked the question, is digital better than film? Because clearly digital is a whole lot more expensive. It cost us several $1 million to convert our breast center into digital. But because of that trial, we learned that probably about 60% of our population we would be able to find breast cancers more efficiently using digital. That the breast cancer was more obvious. We could see through densities a little better. You know, the contrast between that cloudy sky and the blue sky was better, so we could find abnormalities easier. And that was really in about 60% of our population. So that was again another landmark study that said this is how we can find breast cancer better.
Yeah. That digital has been transferred over to mobile mammography, a big program we have here. I believe we touted that we have the first mobile mammography unit west of the Mississippi.
That's what we say.
And the image of the old one we have, and that's the old unit there. Streamline trailer. You guys took it on vacations.
Took it on vacations, then put an X-ray machine in it.
Right. And so. You translate that to the van we have now. And by the way, this is just, I go on tangents a lot, as you know, but this is the only photo I could find on short notice in cornbread. I remember this day. It was 20 degrees outside, and the guys wearing shorts, and it was really windy because your hair's blowing all over the place. But that's beside the point. So you can see, doing the Pepsi challenge
Right.
of the old van versus the new van, we've
Right.
kind of moved a long way. So the digital mammography is also on the van as well.
Mm-hmm.
So what do you guys do with the van? How does that work as far as taking mobile mammography to the patient rather than the patient coming to us?
So that the big pink van that you just saw there I clearly remember the freezing cold day. It was really, really
But you
cold.
weren't wearing shorts. Yeah.
But no, and that's why we love cornbread.
Yeah.
because
And by the way,
does
Cornbread, if you don't know, is an FM morning host on WYL, a country station here in St. Louis, who's a big champion of the cause
absolutely
of breast cancer.
huge champion of,
Right.
of the cause. So that van that you see is exactly the same as one of our exam rooms in the breast center. We can do everything from a screening perspective on that van that we can do in the breast center. So imagine the old Airstream. Women had to come in one at a time, and we were one or two at a time. We had one changing room. It was the size of an Airstream, which is not nearly the size of our 36-foot monster truck now, but and we had an X-ray machine on there in a suitcase where the techs would shoot the pictures, put them in a suitcase, take them to the breast center later in the day, and develop them. Our second van, which we took off the road probably 5 years ago, we made a lot bigger. We put 2 dressing rooms in it, so we would always have one woman being imaged, one in either dressing room. So we learned how to move women through a lot sooner. We also added a developer on there. So the women would have their mammograms. The tech would take the picture. We would develop it right away, and then that saved us a lot of steps when we got back to the breast center. So now let's move forward to 5 years ago when we learned that we really need to do digital mammography on everybody to capture that benefit of finding cancers better in a big part of our population. So we knew we wanted to recreate that digital screening room like we have inside, and so worked with the company that built the van and worked with the company who sold us the technology to make sure that we could do everything on that van that we can do on the inside. And so it really has just kind of come full circle. We're sort of waiting to see what's going to happen with breast tomo. Again, Dr. Monsies is really excited about breast tomo in the mobile environment because we go really far with that van. We go as far down as Sykeston and Kennett and take care of women down there. So if we can get that three-dimensional picture and avoid women from the boot heel or in more rural areas having to come back in, that is just really, really exciting for us. So we know that breast tomo isn't ready for the mobile environment yet, but we are hot on the tails of the people who have developed the technology to get it ready.
Yeah. There are some people watching this, and thank you for doing so. Survivor Runner, who is you weren't there when we were at Channel 5 recently in the morning. The fan, you might remember that.
Yes, I remember.
Inside story. However, she's a breast cancer survivor, a patient of ours, and she's thanking us for doing this. But one of the questions we had on Twitter from Teresa Lieb was, what alternatives do you have other than surgery to shrink a tumor? Okay,
so surgery doesn't really shrink a tumor, Teresa. What surgery does is lift the tumor out. So quite often, and again, I'm by no means a medical oncologist or a breast surgeon, but I know that there are chemotherapy techniques, and if you have the right sort of tumor that they think will respond, you may get a couple of rounds of chemotherapy called neoadjuvant chemotherapy, where it is amazing how if we find a tumor that's small because you've had your annual mammogram and we know that it will respond to this neoadjuvant chemotherapy, we can just about shrink some tumors to nothing. And so then when you go to have your surgery, instead of having this much cut out of your breast and perhaps changing the architecture and the appearance of your breast, it's a very minimal surgery.
We also had a question emailed. If you've had breast reduction surgery, does the scar tissue sometimes present as a mass?
And I'm sure that it can, particularly within the first several months of having the reduction surgery. Everything is sort of changing around in there and scar tissue is forming. That's why it's really, really important after you've had breast surgery to keep in close contact with your surgeon and follow the surgeon's recommendations for clinical breast exams and follow-up of that, because you really want to know what feels like scar tissue and what may be different, because you haven't taken out all of your breast tissue when you've had your breasts reduced, and absolutely you can still get breast cancer.
Yeah. Now, one of the questions I wanted to ask, and not every program is set up like ours, but if a woman gets a mammogram, how does the multidisciplinary setup that you have work, where surgery is right next door and they can perform a biopsy? How does that work if you get a mammogram performed and something is found?
Right. Okay. So when the building that the breast center is housed in was designed, it was designed very strategically to have the breast imaging suite right down the hall from the breast surgery suite, right across the hall from the OBGYN practice, and down the hall from internal medicine. The operating rooms are one floor below us, and the cancer center are 2 floors up. So we really have this whole breast cancer world within 2 floors of the Center for Advanced Medicine. So and this happens at the breast center every day. A woman comes in, she's found something abnormal, or we found something abnormal on her screening mammogram. She'll come in for more pictures. If it's something that is suspicious, but we think that it's okay for her to go home and get prepared and maybe bring somebody back with her to keep her company while she's having her biopsy, we'll do that. And we really have found that women are much less anxious if they have a chance to spend some time with one of our 2 nurses, talk about what they found on the mammogram, go home, discuss it with their family, come back in a day or 2 and have their biopsy. If it's something that we're really worried about, or if it's someone that's from very far away, we have the capability to absolutely say, let's do a biopsy on this right now. And we do what are called minimally invasive core biopsies, where we go in with a special needle and just take some samples. It's not, we make a very, very, very small incision and go in, take some samples, get that to pathology, and we have results in a couple of days. If it's something that we really think we need a surgeon to look at right away, our surgeons are steps away from the radiologist, and often in our reading room or in the surgery practice, we can see radiologists and surgeons interacting all the time. We're really, really lucky to have that.
One other question we had was from Shannon, who emailed, what is IBC? Now it would be inflammatory breast cancer.
Yes.
This took off about 6 years ago, where a TV station in Seattle did a pretty sensational sweeps piece about inflammatory breast cancer. They called it IBC, which at the time no one called it. Right. IBC is a very delicious root beer. And in doing so, it spread virally, and people freaked out about this. Right. What is inflammatory breast cancer?
Absolutely, people freaked out about, Jason. It was insane. Inflammatory breast cancer, and incidentally, they also tagged inflammatory breast cancer as the new breast cancer.
Yes.
And
yes.
I'm here to say that it's not new. I actually lost a sister to inflammatory breast cancer 15 years ago, 10 years before the new breast cancer was invented. It's a very tricky breast cancer is what it is. It doesn't always present as a lump. It may even present as just a pimple on a woman's breast, a hot spot. It's very tricky. Sometimes it's hard to diagnose. You may go in, and this is absolutely true, absolutely what happened with my sister. She had a spot on her breast. She had just finished nursing a baby. And, that's probably a milk duct. Don't worry about it. And, a couple weeks, it kept getting hotter and hotter. And finally, it never really showed up on a mammogram. But because she came to our center here, they diagnosed it relatively early. And we've learned a lot more about it in the last 15 years, but we had her for a lot longer than we thought we would. It's really something that it's one of those breast cancers that if you notice a change in your breast, you need to let your doctor know. That's why we don't say, yeah, you need to examine your breast on the 3rd of the month, but we say you need to know what looks different, what feels different. And if something changes during those periods where you've done that breast exam, let your doctor know.
So are you saying what was on the news wasn't accurate?
Imagine that.
Yeah, it happens. I'm sorry.
Does.
Well, so overall, message we want to get out to women. Annual screening at 40. How often should women do breast self-exam?
Women should do breast self-exam often enough to know what their breasts feel like. So, they absolutely should take the time to learn how to do a breast exam, and your doctor or healthcare provider should be able to teach you how to do that, and do it regularly enough to know what it feels like, to know what your breast tissue feels like and know when something's changed, and then to make sure you let somebody know that something has changed.
Okay. Well, Susan, thank you.
Thanks, Jason.
Thank you. And also thank you to the staff here at BJC Media Services for all of their work and for putting the potted plant over my left shoulder, because I was really excited. There was supposed to be a potted plant last time, and I turned around and it was gone.
It's a lovely potted plant, Jason.
And you got to have a porcelain tower to set it on, because
a little bit of green always works.
It does. I mean, look at that shot. It looks beautiful with that. I mean, you got to have that. So thank you. This is the 4th Wednesday webinar we have done here at Barnes Jewish Hospital. We will have the full list and a schedule up on our website, www.barnesjewish.org. And we will update you consistently on the schedule of these on Twitter, www.twitter.com/BarnesJewish, Facebook.com/BarnesJewishHospital. And you can always email us at barnesjewish@bjc.org. Thanks for everything. We'll see you next time.